Welcome to the eMedica MRCGP AKT High Yield Revision Webinar 2020. So what we're going to do, we're going to cover 15 different questions, okay, exam style questions covering key topics. Every single one of these topics are topics that have been highlighted by examiners in a recent examiner's report as something that trainees in recent exams struggled with. These kinds of topics, which I called high yield topics, they tend to be featured again and again and again. Okay, so what we're going to do first of all 5 questions one at a time. So we're going to split this into 3 parts. First part, we're going to do 5 interactive questions one at a time. Please do write down the question numbers and whether you get it right or wrong if you want to see how you're doing by the end of the session. Okay, then part 2, we're going to do a timed mini mock, just 10 questions, but you'll do all 10 in one go before we go through the answers, because I want you to start developing exam technique and get used to the optimum pacing if you want to finish the exam and have a few minutes left to go over some questions that you might have flagged earlier, okay, in the real exam. So there'll be 10 questions. So by the end of this session, we will have covered 15 questions. And if you number on your paper 1 to 15, you can see how you've done out of 15 and then work out how you're getting on. Part 3, we're going to do revision planning. And I'm going to talk about those that are sitting the exam in July, what to do for these last sort of 2 weeks that you've got left. And those that are sitting in August, you've got 6 weeks left, what to do in that 6-week period, okay? And then there'll be time for questions and answers at the end of the whole session, okay? So we're gonna go straight into it. Here we go, first question. And that's time. Thank you very much. So the 2 most popular answers were A and C. So A, the hearing in the right ear is mostly in the normal range, and C, this is consistent with a conductive hearing loss in the left ear. In fact, C, conductive hearing loss in the left ear, was the most popular answer. 40% of you picked that. Every answer option was picked by at least a few doctors. Okay, so it just highlights the hard question. We know that ENT, alongside with genetics, are the 2 clinical areas in the curriculum that candidates do worst in past exams. Okay, so don't worry if you find this difficult, that's why you're here. So the correct answer is A, okay, that the hearing in the right ear is mostly in the normal range. So let's have a quick look at this. First thing is that both of these are showing 2 different ears, okay? The right ear is always shown in red, so this is the right ear, and then the left ear is shown in blue, this is the left ear. In both cases, what is shown here is air conduction. Now, when they only show air conduction, and they don't show bone conduction, you can't tell if there's a conductive loss. Usually, this is what they show when there's a sensory neural loss. When there's a bone conduction and air conduction shown, and you see a gap in the same ear, so for example, if you saw in the same ear that bone conduction up here was normal, bone conduction is always shown with brackets, and air conduction was down here, that gap tells you that there is a conductive loss, because, you know, imagine you've got a cholesteatoma or you've got a big otitis media with an effusion on this side, okay? Can you see the bone conduction will be normal, but the air conduction will be slowed down either by the fluid or by the mass. So in this case, bone conduction isn't shown at all because there are no brackets on here. This is typically what you will see when it's a sensory neural hearing loss, okay? So that's why C and D are incorrect, okay? We can't tell if there's any conductive loss because we aren't shown the bone conduction, okay? If we look at the other options, the hearing in the left ear is mostly in the normal range. Actually, look, remember, right ear is red, left ear is blue. Look at the left ear, okay? Here, it's okay. It's a little bit reduced, but look over here. It's significantly lost, okay? These 2 are wrong because we aren't showing any bone conduction. And then E, both ears show mild hearing loss in the low frequency. Actually, if you look at the right ear, these are the low frequencies. This is in the normal range, okay? 10 to 20 is in the normal range. There is a little bit of drop here in the very high frequencies. You can see in the left ear, which is blue, even in the low frequencies, there's loss, and then in the higher frequencies, there's significant loss. So this is typical of what you would see in a sensory neural hearing loss, and the fact that it's only one ear. Any one put into the chat, what type of hearing loss might you see this type of pattern? What type of sensory neural hearing loss? I'll give you a clue. It's the second most common type of sensory neural hearing loss. So what kind of hearing loss might we see this kind of picture? So a couple of people have said presbyacusis. So presbyacusis is frequently bilateral. You do see loss in the higher frequencies, but it's usually bilateral. Usually you'll see this in noise-induced hearing loss, okay? Where, you know, one ear is significantly affected, but the other is effectively normal, okay? And it's sensory neural. Okay, so A is the right answer, okay? Okay, so let's have a look at how to interpret audiograms. So bone conductions are always shown with brackets, either square brackets or triangular brackets like this. So B for bones, B for brackets, okay? Air conduction, one ear is shown with a cross, one ear will be shown with a circle. Remember that air passes through a circle. And then if they've not labeled the ears, just remember R for red, R for right. The right ear will always be in red, and then the left ear is therefore going to be in blue, okay? So this is what you'll see typically in a conductive loss. You see in the same ear, the bone conduction is normal, but there's a reduction in the air conduction, so there's a gap. But you see, it's in the same ear. In this case, this is bilateral conductive hearing loss, okay? Here, this is what you'd see typically in presbyacusis. In both ears, typically, it's bilateral usually. The very low frequencies are in the normal range, but as we get to the high frequencies, you get significant loss. This is the most common cause of sensory neural hearing loss, the hearing loss of old age, presbyacusis, okay? Question number 2. Here. Okay, that's time. Thank you very much. Okay, so again, highlights a difficult area. Every single answer option has been picked, okay? This was highlighted in a examiner's feedback report a couple of exams back, okay? Men's health generally, people often struggle with, but specifically this type of area was featured, okay? So the most popular answers are A, B, and D. A, B, and D, okay, of which D was the most popular, followed by very closely by B, okay? So first of all, what do you think the diagnosis is? This is an example of what we call a two-step question. You get the mark for the second step, which is management, okay? But to work that out, you first want to work out the diagnosis. So feel free to type into the chat what you think the diagnosis is, okay, based on this picture. So 4-day history in someone in their 50s, swelling of one scrotum, pain hasn't changed much in 2 days, no recent trauma, ibuprofen helps, okay? Recently had a UTI, no sexual activity recently, and Pren sign is positive. That's really, really important, okay? Pren sign is positive, okay? So yeah, this fits with epididymal orchitis, doesn't it? Okay? If this was someone much younger, and if, for example, it was exquisitely tender rather than moderate tenderness, then you might think about torsion. Common things are common. This is very, very unlikely to be torsion, okay? This fits with epididymal orchitis. Now, epididymal orchitis, there's two variants. In terms of what's caused it, you can get it in relation to an STI, you can get it in relation to a UTI. So the second question, do you think, in this particular patient, do you think it's more likely to be related to a UTI, or is it more likely to be related to an STI? Because that's going to govern what we treat it with, because you treat it differently if you think it's likely to be a UTI compared, yeah, it's likely to be a UTI, right? Okay, so that's why the right answer is D. Levofloxacin, 500 milligrams, once daily for 10 days, okay? So epididymal orchitis, if we look at the presentation, usually it's a gradual onset over a period of days. It's painful, it's moderately tender. You will usually be able to palpate a swelling. There will be some erythema. And then another big clue here that helps us to try to separate it from torsion is Pren sign. So Pren sign is where you elevate the testes And if the pain goes when you elevate it, that's Pren sign positive. Pren sign is positive in epididymal orchitis. It's usually negative in torsion. Okay, so there were a lot of clues here to make us think of epididymal orchitis. Now, if they had really severe symptoms, like the patient was running a very high fever, acutely unwell, and you think they might be, septic, then we'd admit them. Otherwise, this hardly ever needs admission. Usually what we would do is refer them to gum clinic within 24 hours, or some patients don't want to go to gum clinic, then we can treat them in general practice. And we treat based on the likely cause. So if we think it's likely to be STI or especially gonorrhea, then ceftriaxone and then doxycycline, and then you can add azithromycin, or you can give it without azithromycin, but you give both ceftriaxone and doxycycline. If you think it's likely to be an enteric organism, i.e. related to a UTI, and they're low risk for STI, this patient hadn't had any sexual activity for over a month. Okay, symptoms are only in the last few days. So you see an STI variant is very unlikely in this patient. Okay, so then the two choices are either ofloxacin for 14 days or levofloxacin for 10 days. So if I go back to the scenario, it's a really hard question, because first you've got the knowledge base to know what the guidelines are. The second part is reading carefully to pick up the technique. So we worked out the diagnosis is more likely to be epididymal orchitis. If we thought it was torsion, then we'd think about admitting to hospital for surgical management. So, younger patient, Pren negative, that's what we'd go for. Okay. B, if they were likely to have an STI, then B would be the correct answer, i.e. ceftriaxone and doxycycline. This is how we're going to manage if we thought it was gonorrhea. Okay. This, right drug, but look, it says single dose. There's no scenario where you use ofloxacin as a single dose. Things like ceftriaxone sometimes, IM, high dose, 1 gram, given as a single dose. But ofloxacin is usually given for a 2-week course, okay? So that's why this one's incorrect. Right drug, but wrong dose, okay? D was a correct answer. And then E, azithromycin is never used as monotherapy for this. You might add it to ceftriaxone and doxycycline in some patients, okay? Number 3, here we go. And that's time. Thank you very much. Okay, so the two popular answers were A and B. No one picked E, but all the other options were picked. Okay, so A and B are the two really, really popular answers. Okay, so first of all, what we're looking for is whether or not we want to give antibiotics in this patient with sore throat. So in terms of evidence-based medicine, what scoring system might we use to decide if you're going to give antibiotics, deny antibiotics, or give a delayed script? Great, fever pain, good. Okay, so what do you think this patient's fever pain is? Type that into the chat, because that's going to help you determine, how you actually manage the patient, right? Okay, so we've got 1, 2, 3 so far, okay? Great, okay, well, that probably explains why we've got the variety of answers. So the correct answer here is B, offer a delayed script for penicillin V. Okay, so clarithromycin, option C and option E, which some people did pick, that would only be suitable if the patient had a penicillin allergy, and that's not mentioned anywhere. Okay, advise no need for antibiotics, that would be if they had a really low score. Okay, but this patient hasn't got a really low score. Based on their score, actually, there's a moderate probability that they've got a bacterial infection, and that's why they'd be offered a delayed script. If they had a high probability, would actually start today penicillin V. Okay, so let's go through the criteria, and then we'll come back and we'll look at this patient's score together. So fever pain, you score 1 for each of the following. Fever in the last 24 hours, you get 1 point. Now that is self-reported. If the patient says they had a fever, or in this case, the parent says they had a fever, it doesn't matter if they haven't got fever today. That's one of the bits that a lot of people miss out on. Okay. P is having pus, purulence, okay, pus on the tonsils. A is attending rapidly, attending within 3 days or less from onset of symptoms. I is inflamed tonsils, and N is no cough and no coryzal symptoms, i.e. no cold-like symptoms. So if they score 0 to 1, very low probability that they've got streptococcal infection. Don't give antibiotics. 2 or 3, there's a moderate probability, consider a delayed script. 4 or 5, there's a high probability, consider starting antibiotics today. And first line is Pen-V for 10 days. If they were allergic, then you might use clarithromycin or erythromycin, which are 5 days. So if you go back to this patient, so look, 2-day history, so they get 1 for attending within 3 days, okay? Fever of 38 earlier in the day, even though today they're afebrile, they've had a fever, they get a point for that. Self-reported fever, you have to count as a point. And then the tonsils are inflamed, they get a point for that. So the fever pain score is 3, moderate probability, delayed script, okay? Question number 4. Okay, that's time. Thank you very much. Okay, so every single answer option has been picked. Again, this is the admin domain, the domain that doctors do worst in the AKT. Okay, so again, I'm not surprised if you find this difficult, that's okay. The most popular answer is E. Just over half of you picked E. After that, A, C, and D were all very, very close. Okay, so he can't access Data Protection Act and Access to Medical Reports Act, all very, very popular. So, you know, close seconds, basically. The one that was least common, but a few people did pick, was B, advise him to contact Patient Advice and Liaison Service at the local hospital. So correct answer here is E. Because he wants to access records of someone else who's passed away, and he's the next of kin and the executor of the will, so he's got a right to access it, okay, if he's got a legitimate reason. Then the act is the Access to Health Records Act. The Data Protection Act is used to access your own information. You couldn't use that to access someone else's information. You can see he wants his father's notes here, not his notes. You can't use the Data Protection Act for that. And then Access to Medical Reports Act is used by employers if they want to access an employee's health records for occupational health reasons, okay? So that's why the right answer is E, okay? So key acts in relation to medical reports, Data Protection Act 2018, and at the moment also GDPR, the General Data Protection Regulation, which is an EU law. That won't exist anymore in the UK after transition's over, which is why the Data Protection Act was updated in 2018. This is to access your own information. Access to Medical Reports Act is for companies that want to access information about their employees in relation to occupational health matters, i.e. if the health might impact their job role. And the Access to Health Records Act 1990 is to access someone else's records who's passed away. You've got to either be the next of kin or the legal executor of the will, or have permission from them and have some legitimate reason. Like in this case, they thought that, you know, their father had had negligent care and they wanted to sue the practice. That's the legitimate reason, okay? Okay, last one in this section before we stop. And that's time. Thank you very much. So again, every single answer option has been picked. The most popular answer is B. After that, C, D, and E are about equal. Okay, so Smith et al. 2005 most popular, then Smith et al. 2007, Chung et al. And Jones et al. 2010. Very few people picked Jones et al. 2000, although 5% of you did pick that. Okay, so first of all, what is the name of this type of graph? It's got two names. Anyone want to type that into the chat? The name of this type of chart. So it's called a forest plot. That's one name. What's the other name for it? It's also called a blobogram. Okay, they mean the same thing. It's called a blobogram sometimes because each of these in the middle is one blob. Basically, each of these is one study. The bigger the blob in the middle, the greater the weight of that study. Usually that means it had a bigger weight, okay? And it's a visual way to represent a meta-analysis. So there are multiple studies that were looking at the same thing. You can see all of these studies were looking at the potential impact of drinking alcohol and suffering a minor injury. And the way that they're normally laid out is in chronological order. So the earliest study is at the top, the most recent study is at the bottom. And that's why, can you see, often, you know, Smith is the lead researcher in a 2005 study. Often, if they're doing a follow-up study, they're going to lead it again. Similarly, look, Jones et al. Led this study. 10 years later, he led this one, but this was a much bigger study, okay? The diamond is representing the pooled data mean, i.e. it is as if you had one huge study adding all of these. These are individual studies. This is the summary measure. It's the mean, the adding up of all of these as if you had one study. And the mean finding is this dashed line, okay? So which study showed the widest 95% confidence interval? So the way that you look at that is the horizontal line, and then this is it in numbers. So the odds ratio here, you can see it was actually 1.3, but a 95% confidence interval of 0.5 to 2.6. So the first thing you can do in questions like this is you narrow down by eliminating things that are clearly not the right answer. So it said, the question says, which showed the widest. Okay, so you can see these two are not very wide. Okay, so we're going to eliminate them. We don't need to calculate the difference between 2.7 and 1.9, which is what gives us how big the range is. Okay, we don't need to do that because you can just see these are not anywhere near as wide as these. And so you're left with these three. And if you look at these three, this doesn't look as wide. It's going to be one of these two, either Smith et al. 2005 or 2007. And so here you'd look at the numbers. 3.4 minus 1 is 2.4. 3.2 minus 0.9, it's not quite there, is it? So the right answer is B, Smith et al. 2005. Okay, so well done. Most of you actually got that right. I think just over half of you got that right. Okay, so well done. So can you see, I eliminated just by eyeballing these two, and then you can see this looks slightly less wide than these. So I won't bother calculating this one. I'll calculate these two. 3.4 minus 1 is 2.4, okay? And then here, 3.2 minus 0.9 is 2.1. So this is the bigger number. It's the widest range, okay? So Smith et al. 2005, all right? And then the other bits of the forest plot, okay? So the size of the blob is the weight of the study. Most of that's to do with numbers. So if you've got a study with 10,000 patients, it's gonna have more weight than a study with 5,000 patients. But sometimes if you've got two studies with the same number, two studies with 5,000 patients each, one was unblinded. That means the patient and the researcher knew if they're getting the placebo or the active drug. And one was double-blinded. The researcher and the patient didn't know. The double-blinded one will be given slightly more weight, okay? The dashed line that runs down the middle of the diamond is the mean finding from all of the studies combined. The line, which is solid, which goes this way, okay? So vertical line, where the odds ratio or relative risk is 1, is called the line of no effect, okay? If the 95% confidence interval, which is the horizontal line, touches or crosses this line, then you can say that the findings from that study are not significant, okay? So those are the different bits of the forest plot, okay? So let me just clear any questions before we do the mini mark, okay? So a couple of people asking about, for the question with the sore throat, how about using Centaur? So the reason that we would use fever pain is that fever pain has a stronger evidence base, it's much more accurate, and it has a better grading, and so it's recommended over Centaur. Centaur is a lot less accurate than fever pain. So when would you use Centaur? I would never use Centaur. I would use fever pain every time, okay? That is one question at a time we've done, and then done rapid reviews, okay? We covered some questions from stats, admin, and clinical, all right? In terms of this style of learning, covering one question at a time, worked examples, going through why the questions that you got wrong were wrong, and then doing a rapid review of the relevance guideline. If you find that type of learning helpful and you'd like to cover stats, admin, high yield clinical, either or all of them, Then our AKT Masterclass webinars are running on the 21st, 22nd, and 23rd of July. For those of you sitting the August exam, you could attend that live. So the 21st is statistics, 3 hours. The 22nd is organizational domain organized, 3 hours. The 23rd is high yield clinical topics, 3¼ hours, because there's more high yield clinical topics mentioned by examiners. And for those sitting in the July exam, we have the recorded version of these that are recent, so they're up to date. You can get instant access to any of these, okay? So statistics, we cover all of these topics and more with worked examples and exam style questions. We'll go through more than 40 questions in that one evening. And you can see some of the feedback. We've helped people get 100% in stats, 100% in stats, 95%, 90%. These are people that didn't like stats before, okay? So master all the key stats in 3 hours of intensive learning. Organizational, we'll cover all of this and more, basically all the key topics that you need to do really well in 3 hours, okay? Again, we've helped lots of people get 90, 95, 100% in the admin, okay? You know, getting really, really good scores in this will help you get away with 70 or so in clinical and pass. And then high yield clinical has the most questions, over 50 something questions we go through, because we cover every clinical topic that examiners mentioned in their reports from the last 10 years worth of examiners reports, okay? So these things come up again, again, and again, okay? So that's why it's a bit longer, 3¼ hours of intensive learning. Okay, so if you want to sign up to any one of them, it's £79. If you want to sign up to all 3 of them, it's £199. If you hang around to the end, I'll give you a discount code that will work until tomorrow that will allow you to get a 15% discount, okay? So we're going to move on to the mini mock exam now, okay? So we're going to do 10 questions, 55 seconds per screen. The reason we're going to do 55 seconds per screen is in the real exam, if you want to finish the last question as the buzzer goes off, you've got 57 seconds per question to get through your 200 questions. At a pace of 55 seconds per question, you will build up 10 minutes to go over any that you were unsure of at the end. And that can help you for any you flagged and you want to just go back to, 20, 38, 112, just those few that you struggled with, you can come back to if you build up 10 minutes. So what will happen is here, I won't launch any polls when we're doing the questions. We'll look at that later. I won't give you any answers or explanations after each one. You're going to do all 10 in one go. Just write down the question number and your answer, okay? The question numbers will start from question 6 because we've already done 5, all right? And then after you've done all 10, I'll come back online and I will go through the answer and explanations with you, okay? So exam conditions, here we go. Okay, that's time. Well done, everyone. Okay, so we're going to go through the answers now. Okay, you get 1 mark for each fully correct answer. Remember, where there's a multiple best answer, i.e. there's more than one right answer, if you get part of it right and part of it wrong, you don't get half marks. You don't get partial marks in the AKT. You either get 1 or you get nothing. Okay, so what I'll do is I'll launch the poll for some of these. I won't launch the poll for all of them, just because of time, but I'll launch the poll for some of them just to see the ones I'm particularly interested in. Don't be calculating it or thinking about it now. You've already written down your answer. I'm just giving you 10 seconds, that's it, to put down what you've already selected. Okay, okay, great. So nobody picked D, 100 milligrams over 24 hours, but A, B, C, and E are all about equal. Okay, so A, B, C, sorry, C was a bit more popular. C was the most popular, but A, B, and E about equal. Okay, so he's on 120 milligrams twice daily of modified release morphine. So that's 240 milligrams in total. And you're going to change to diamorphine in a syringe driver. So what you've got to do is you've got to divide by 3. So 240 divided by 3 is 80. So correct answer is C. So well done. A lot of you got that right, actually, but quite a few people picked A, which would be far too low a dose. Okay. Then we had quite a few people also picked B, which also isn't going to be enough. And then lots of people picked E. This will be the dose if you are going to convert to morphine in a syringe driver. Morphine in a syringe driver, you divide by 2. It's twice as powerful as morphine orally. So 120 milligrams oral morphine twice daily is 240. Conversion from oral morphine to syringe driver diamorphine, you divide by 3, whereas to syringe driver morphine, you divide by 2. So 240 divided by 3 is 80. Okay. So we calculate the 24-hour oral morphine, including any breakthrough doses. This particular patient was well controlled. They weren't using any breakthrough. You can see they're well controlled. So all we had to do is divide by 3. Okay. If it was morphine, we'd divide by 2. So for example, popular oral morphine regimes. Someone right at the beginning, you might start them on 15 milligrams modified release twice daily. Okay. So i.e. 30 in total. If you're going to convert them to syringe driver morphine, that would be 15, or syringe driver diamorphine, it'd be 10, because you divide by 3 for diamorphine, divided by 2 for morphine. And then if we look at opioid conversions, because palliative care and cancer pain management, another really important area for us in GP, but an area that people often do struggle with. You add up the total dose. Sometimes they'll ask you, what about the breakthrough dose? In real life setting, we'll use somewhere between a 10th to a 6th of the 24-hour dose for the breakthrough dose, which is like where you give a single dose, right? In the exam, generally, they'll use a 6th for the 24-hour dose, okay? So morphine oral is the universal opioid. You work out the oral morphine equivalent that they're using. If you're then converting to an injection of morphine, whether it's IM or subcut, you halve it. Oxycodone is about 1/3 stronger than oral morphine. Okay, so 10 of morphine is about 6.6 of oxycodone. It's stronger. Okay, this is really suitable where someone can't tolerate morphine. Diamorphine, if you're giving IM or subcut as a single dose, it's actually just over 3 times as powerful. 3 milligrams equals 10. When we put it in a syringe driver, we just divide by 3 to make it easier. Okay, that's according to the BNF guide, which is what the exam will use to base their answers on. And then codeine and tramadol, the weaker opioids, they're 10 times weaker, both the same strength, but 10 times weaker than oral morphine, i.e. 200 of codeine is the same as 20 of morphine. So generally people aren't on 200, they're on 240, which is 60 milligrams QDS. So, that's the same as 24 of oral morphine. Or if someone was on top dose of tramadol, which is 400 of tramadol, that's the same as 40 of oral morphine, okay? Okay, so the second question was about genetics. It's another area that I mentioned, ENT and genetics, 2 areas that people really struggle with, okay? In terms of the clinical domains. So let's see what people thought. Now you can see EMQs, they come in sets. The answer options are the same in all of the set, just the question changes, 1 question per screen. Okay, good. So popular answers were C and D, so 25% or 50%. So correct answer is C, 25%. So well done, most of you got that right, but a lot of people picked D, 50%. So something really important. Often, those that got it wrong, it's not a lack of knowledge, it's a lack of technique. You can see the fact that he said that they're carriers, it has to be a recessive condition, because if it was a dominant condition, you can't ever be a carrier for a dominant condition. You either have it or you don't, okay? And so even if you didn't know, you could work it out from the text, okay? So if you got 2 second cousins, they're both carriers, the risk of children having the disease is 1 in 4, okay? And so sometimes it's just misreading. Let's do the second one, okay? So same cousins, both carriers. Now they want to know the risk of their children becoming carriers, i.e. not having the disease, but becoming carriers, okay? So now this is the one that's 50%, isn't it? D. So again, more than 90% of you got that one right, okay? Again, those that got it wrong, it may well be just misreading what the question's asking. It's not asking how many of them will have the disease, but become carriers, okay? So look, hemochromatosis is autosomal recessive, okay? There are many other autosomal recessive conditions, right? It'd be the same for any of them, like sickle cell, like thalassemia, like cystic fibrosis, okay? So look, mom's got one hemochromatosis gene and one normal gene. They're a carrier. Dad's got one hemochromatosis gene, one normal gene. You get one from your mom, one from your dad. So look, the chance that you become full-blown disease, you have to get two hemochromatosis genes, i.e. one from your mom and one from your dad. There's only a 25% chance that will happen. You've got a 50-50 chance that you get a faulty gene from either parent and become a carrier. And then you've got a 1 in 4 chance that you will have two healthy genes. Not only will you not be a carrier, you cannot pass it to the next generation, okay? So 50% carriers, 25% will have disease, 25% will be healthy non-carriers if both parents are carriers for an autosomal recessive condition, okay? And then the last one in this set involved a little picture looking at inheritance. This is called a pedigree chart, okay? Using standard pedigree symbols. So great, so this one, not as clear cut as the others. So A, 0%, C, 25%, and D, 50% were all picked, okay? So what's the patient's risk of Huntington's? Well, Huntington's is dominant. You can see, look, here, father's got it, mother's healthy. There's a 50-50 chance that the kids will get it. Okay, similarly here, mother's got it here, okay? Father's healthy. What's the risk? The risk is 50-50, okay? So D is the right answer, 50%. Now, only 2/3 of you got that right. So 1/3 of people, that's quite a lot, got this one wrong. Now, I'm going to show you another bit of technique here. It's what I call the EMQ trap. If we go back, the question before was D, 50%. So some doctors, what they do is they actually knew that the risk is 50% if one parent's got it and one has an dominant condition, okay? But then they would have looked up on their piece of paper. In the exam, they would have said, didn't I just put D? They would have clicked previous ones. They would have said, oh, I've just put D. Why are they putting 2 Ds in a row? I think they're trying to get me. And then they would have changed a good answer for a bad one. So, you might have changed D to C because you thought there was a pattern and someone's trying to get you. No one's trying to get you. We want you to pass this, pass your other exams, get your CCT, come and help us see patients on the front line. That's what we want. We're on your side, okay? But some doctors, when does this happen? This happens when you don't have confidence in your own knowledge base. So this is really important, confidence. A lot of people think confidence just for the CSA or the RCA, even for the AKT, being confident in your knowledge that, look, I know this, that's why this is the right answer. And then you just put it in an EMQ. If D is the right answer for all 3, put D down for all 3. Don't go looking for conspiracies, okay? So look, if one parent's affected and the other isn't, there's a 50-50 chance that you will have the disease if it's an autosomal dominant condition, okay? And these are the modes of inheritance of relatively common for the UK population and therefore important for the exam disorders. So dominant recessive, X-linked dominant recessive, polygenic, and chromosomal, okay? Question number 10. So this is an interesting question because, again, something very important about technique. But there's also a knowledge side here because a lot of doctors, haven't read some of these guidelines in the admin domain. Okay, it's an area that people often find difficult to read. Okay, that's fine. Thank you very much. Okay, so the most popular answer was B and E, and then after that it was F. So lots of people picked F, and after that it was A. So here, this is what we call a multiple best answer. Which 2? You have to get them both right to get 1 mark. If you get 1 right and 1 wrong, you will not get half a mark. You get 0 marks. Okay, so it's a challenging question type, a multiple best answer. So the key things here is that it says in relation to GMC guidance on gifts. Okay, and so the correct answers are B and F. Okay, so actually less than half of you would have got a mark here. And that's because lots of you picked B, but not that many people picked F. Lots of people instead picked E. Now, the GMC sets no maximum value. Why did some of you pick E? Because GMS guidance, GMS is one of the 4 types of NHS GP contract. There's GMS, PMS, APMS, PCLMS, okay? In the GMS contract, high value gifts need to be declared. That's £100 or more. But GMS has got nothing to do with GMC, and the question is about the GMC guidance, okay? So reading carefully, another really important part of exam technique. You can have all the knowledge in the world, you misread the question or something important in the symptoms or something important in the answer options, you will regularly drop some marks here and there, and over 200 questions that can add up. So option A, you should not accept gifts in the form of money or vouchers of any value. That's not true. It's fine. The GMC doesn't say anything about that, okay? And then they don't set any value. That's why C, D, and E are wrong. Whereas if someone voluntarily gives you a gift, you can't ask for a gift, but if someone voluntarily gives you a gift, you can accept it as long as it meets some conditions. That's what it says, in some situations. And GMC sets no maximum value, okay? So what does the GMC say? You're not allowed to encourage gifts or pressure people to make donations, even if it's to charity. You're not allowed to alter management and the services offered based on gifts. And you shouldn't accept a gift if it might seem like a conflict in interest or you're taking advantage. Like, you've got a patient with dementia, don't accept gift from them. Even if it's a small amount of money, someone might feel that you're taking advantage, right? But if there isn't any of those conditions and someone voluntarily offers you a gift, you can accept it. It's fine, okay? Whereas if you have a GMS contract, so like we all have to obey GMC guidance because we're GMC registered doctors, right? We've got a license to practice. But only doctors that work in a practice with a GMS contract, it's one of the 4 types of NHS contract, have to abide by this, that gifts worth £100 or more must be recorded in a register of gifts held at the practice. It's nothing to do with the GMC, okay? So again, do you see the importance of reading the question, all right? Question number 11. This is another important question because it's an area that people often struggle with, okay? It was highlighted in a couple of exams ago. Okay, that's time. So again, every single option has been picked, okay? The most popular option is A, which is the correct one. So the key thing here is that they've got the small joints of the hands and feet are affected by this persistent synovitis. So you've already given some painkillers, probably an NSAID, and you've ordered some blood tests. Things like rheumatoid factor, ANA, double-stranded DNA, things like that would be useful, okay? But in terms of management, the right answer is A, within 3 working days, right? This is what's considered a very urgent referral, okay? So within 3 working days. So A is the right answer. Well done. About half of you got that right, but that does mean about half of you got it wrong. Most popular answer after this was jointly within 3 weeks and within 1 week, okay? So any suspected rheumatoid arthritis should be referred to a rheumatologist within 3 weeks, but refer even more urgently, i.e. within 3 days, if any one or more of these 3 apply. So small joints of the hands or feet are affected. This patient had small joints of the hands and feet affected. So definitely needs a very urgent 3 working day referral. Or if multiple joints are affected, or if they've already had at least 3 months worth of symptoms, you should not delay referral while you're waiting for the blood test, okay? Okay, and then alcohol, is another area, both calculating units, but knowing, for example, how to screen for alcohol dependence, how to treat someone who's got harmful or hazardous drinking or dependence, is an area that people struggle with in various examiners' reports. Okay, that's time. So the most popular answers were G and D. Okay, G, after that it was D, so 27 and 18. So the correct answer here is G, 27. So well done. Again, just over half of you got that right. That's really good. Okay, so there's two ways. There's the easy way, which is learn how many units are in common types of drink and then just multiply in your head or using a calculator, or you can use a formula to be absolutely accurate. So the quick way, if you know that there's 3 units in a large glass of wine, which is 250 mils, and she's drinking 9 glasses, so look, 7 nights a week, so that's 7 glasses. And on Saturday and Sunday, she also has one at lunch. That makes 9, doesn't it? Okay, 9 times 3 is 27, easy. Okay, the other way is the formula. Units is the volume in milliliters multiplied by the alcohol by volume as a percentage. So that's 12% in this case. That's a fairly standard percentage for wine, by the way. Take that total divided by 1,000. Okay, so i.e. 250 mils multiplied by 12% divided by 1,000. Okay, that gives you 3 anyway. Multiplied by the number of glasses, 9, also gives you 27. It just takes you longer, especially when you're not counting something like glasses of wine, which is 250 mils. If you're counting pints, type into the chat how many milliliters are in a pint, because then you're going to have to get your calculator out because you can't do that easily in your head. How many milliliters are in a pint? 568 milliliters, exactly. You see, you can't really do that in your head. Okay, number 13, the correct answer is H, 30 units, so 750 mils and it's 40% alcohol by volume. Again, if you know that 25 mils of any spirit at 40%, which is a standard strength of most spirits, okay, is 1 unit, then you know that 250 mils will be 10, and therefore 750 mils is 30. You can see I'm estimating to get the answer, okay? You know, 1 unit is a 25 mil shot if it's 40%. So 750 divided by 25 is 30. Or you could say 25 mils is 1, 250 is therefore going to be 10, 750 is 30. Or you could use the same formula. Unit is volume in milliliters, so that's 750 mils, times alcohol by volume as a percentage, times by 40, that's 30,000. Divide that by 1,000, gives you 30. Same answer, it just takes longer, okay? And this is how many units of alcohol are in common types of drink, okay? And in terms of what the latest guidance is, the latest guidance is there's no safe amount of alcohol. Even 1 unit a week can cause harm. But the relatively safe amount, so there's no absolutely safe amount, relatively safe amount is 14 units for men and women. Used to be different for men, but it's the same now for men and women, but with at least 2 alcohol-free days a week where you completely rest the liver. And then common units of alcohol for common sizes. Wine, about 12%, small glass, 1.5 units, that's 125 mils. Large glass, 250 mils, 3 units. Beer, standard strength beer is 3.5 to 4%. A pint's got 2 units in it. Premium beers and lagers, 5 to 6%, a pint's got 3 units in it. Cider's often similar strength, a pint's got about 3 units in it. And spirits, 25 mils of any spirit at 40% is 1 unit. That's sometimes described as a shot, as a single shot, okay? A double shot would be 2 units, okay? And then the formula, units is volume in milliliters, multiply by the percentage alcohol by volume, take that total and divide by 1,000, okay? Right, drug dosage calculations. Every exam has to have at least one of these. Okay, it's in the regulations. So you need to learn how to do these things, okay? So you are allowed your calculators, but I'm going to show you something else that's really important. Just one more question, then we're going to take questions and we're going to do revision planning. We'll finish at 9:15. Okay, that's time. So again, every single answer option has been picked, all right? I'm grateful to see that actually a lot of you have picked D, which is the right answer, okay? But lots of people picked A, for example, okay? Nearly 10% of you, all right? 20% of you got it wrong, 1 in 5, that's a lot, okay? So, A would be far too low, it'd be subtherapeutic. And then some people picked E, that could really harm a child, that's 4 times the dose. And so common reasons that people have made those mistakes. Well, let's do the calculation and I'll show you, okay? So the first thing is this child weighs 16 kilograms and the dosage is 25 milligrams per kilogram QDS. So the first thing is to do 16 times 25, and that's 400, okay? QDS. Now, if the concentration, and this is the actual concentration in the BNFC, that's what they will always use in the exam, is 250 milligrams per 5 mils, then that means that if we do 250 divided by 5, there's going to be 50 milligrams in each milliliter, because we're going to give them a volume to give, right? Okay. So then to work out how many milliliters they need, we'll just do 400 milligrams divided by 50 milligrams per milliliter is 8 milliliters each time, and it's QDS, okay? So that's why D is the right answer. So common reasons people pick A is they then take this and divide by 4. Common reasons that people pick E is that this is already QDS dosing, that they take this, which is already QDS, and then multiply by 4, making a mistake because they've misread the question. So these are the common reasons why people will get this wrong. Now the last bit, which is really important, do a reality check. Are you ever going to give a 4-year-old child 32 milliliters of any medicine 4 times a day, especially flucloxacillin, which is disgusting? All right, just think 32 milliliters is more than 6 spoons. A 5 mil, the bigger side of the spoon, okay? 2.5 mils is the smaller side of the spoon, the measuring spoons they have that come with medicines. So 6 of the big spoons and then 1 of the small spoons, that's what you're looking at 32 mils. Can you imagine giving that to a 4-year-old? It's unlikely, isn't it? Whereas 8 mils, that's like 1 and a bit spoons, right? Okay, just under 2 spoons. That makes sense, all right? Okay, so that's just a reality check that's worth doing. Like similarly, if you do a drug dosage calculation for a morphine and you end up saying that, we're going to get, this patient needs 4,000 milligrams 5 times a day. Maybe, that's enough to put down an elephant. That maybe I've made a mistake in carrying or multiplied too much or something like that. So just do a little reality check. That can be really, really helpful, okay? Someone just saying that exactly that they didn't notice it was already in QDS. Don't worry, that's why you're here. It's a common mistake, isn't it? Okay. Last one, this is from the admin domain, okay? And we're 9 o'clock, so we're just on schedule, because I want to spend the last 10-15 minutes just talking about revision planning and useful resources. Okay, and that's time. Great. So the most popular answers, the most popular was C, consent as long as it's Gillick competent, but actually lots of people picked D and E. So as long as it's Fraser competent, and then it's Gillick and Fraser competent. So the right answer is C. So well done. Most of you did get that right, but a quarter of you got it wrong. Okay. So first of all, there is no such thing as Fraser competent. I do hear a lot of people using this term incorrectly. Okay. There's Gillick competence, and there are the Fraser guidelines. I'll clarify the difference, but there is no such thing as Fraser competent. Okay. So that's why D and E would be, wrong, because this doesn't exist. And also someone can't be Fraser competent. They could be Gillick competent and meet the Fraser guidelines. That could be correct. Okay. So let's look at why. So Gillick competence applies to children under the age of 16. All right. And it's an assessment of their ability or capacity to make their own decisions. So a child who's Gillick competent is someone who's mature. They can make up their own mind, they can make their own decisions and consent to treatments and tests. So they're mature, they understand the proposed decision, they can weigh up the pros and cons. The decision could be about anything. Okay, like this boy who is under 16 and understands, is mature, and he wants to give consent for his own vaccination. That's fine. Okay, he's going on a school trip. Now, the Fraser guidelines only apply if the decision that they're going to make relates to either contraception or sexual health. So it's another layer on top of Gillick competence. So before someone could meet the Fraser guidelines, they've also got to be Gillick competent. So imagine now you had a 15-year-old girl that wants to have the contraceptive pill, okay, to prevent pregnancy. So now we're going to make sure she's Gillick competent, to make sure that she's mature and she understands. But then we also need to meet the Fraser guidelines. One part of that is we try to encourage them to tell a parent that they're starting medication. That's an extra layer. So Fraser guidelines only apply where the decision relates to contraception or sexual health. Okay. Gillick competence applies to anyone under the age of 16 making any decision. All right. So that's the difference. So add up your score. You get a total out of 15, including the 5 that we did, and then the 10 in the mini mock. You get a total out of 15. I'll give you a few seconds to do that. So anyone that scored 11 or more, that would be a pass on any sitting of the AKT ever. Bear in mind, we've only done 15 questions, okay? But of course, in the real exam, 200, okay? So 10 would be borderline. 10 would be just a fail in some sittings. You just miss it by a few marks. It'd be just scraping a pass in some, okay? And then 9 or less, don't worry, okay? It means that you're not there yet. But even if you're sitting in July, 2 weeks is a lot of time if you're willing to put the hours in. If you're sitting in August, you've got lots of time. 6 weeks is a good amount of time, but what it might help you identify, it's just 15 questions. If you did 50 or 100 or something like that, you'd get a much better picture, okay? Like, the stats webinar will do 40 plus questions. The admin webinar, nearly 50. The clinical one, more than 50. Our AKT 200, we do 200 questions like this, okay? So what I would say is that if you're in 9 or 10 or less, you need to look at, one, why did I lose some marks? Is it lack of knowledge? In which case I need to fill any gaps in my curriculum, okay? So in terms of revision planning, you need to complete the whole curriculum. And then you need to look at, have you got a good handle on stats and admin? Because if you can do well in those and get those to 80% plus, you can get away with 70 in clinical. If you don't do well in stats and admin, you need 75 plus in clinical to have any chance of passing. Clinical is the most important domain. It's 80% of your questions. If you get a poor score in clinical, you can get 100% in stats and admin, you're going to fail, all right? But if you can get a good handle on stats and admin, it helps you get away with 70% in clinical, which is very manageable, okay? So in terms of clinical, revise key guidelines. Make sure you've ticked off all of the topics on our high yield topics checklist. This is the checklist I've collated from every examiner's report from the very first examiner's report in 2007. And in terms of exam technique, please make sure you do some timed mocks. You get used to answering questions to time and picking up on keywords and understanding why you got things wrong. So what you need to do is you need to really bulk up your revision. I'll give you a revision plan now for people sitting in July and August. But this is a high yield topics checklist. So, I'll send it to you in the post-course links, which will come to you tomorrow, as well as, the teaching slides, and a link to the recording of this will be available by tomorrow evening. Okay, so basically I've taken all the high yield topics mentioned in examiners' reports. These topics come up again and again, okay? A good number of these topics will be in your exam. So make sure there's none of them that you don't know how to handle well, okay? and just tick them off. And in terms of learning a lot of guidelines in a short amount of time, a lot of you have been on some of our previous webinars. You've probably seen our clinical case cards. We actually nearly sold out of our 2020 run. I think we've got about 7 decks left. Okay, so they're probably going to be sold out by tomorrow. And then there's going to be a delay because we have to get a new batch printed. It typically takes a couple of weeks to come from the specialist printers that we use. So, we've got 112 topic reviews covering the same domains that I used in the exam. So you'll see in the exam, some questions are about the tests you need to do. Some are about making a diagnosis by taking together symptoms. Some are about prescribing. Some are about management, including, knowing who to admit in 2 weeks, who to admit urgently. And some are about emergency. So, a lot of these things are covered here, okay? And then if you found, how we did that teaching mock, 10 questions, and you did them one after the other, to the optimum timing. Well, our AKT 200 mock crammer works in that way. We'll do 4 50-question teaching mocks. So imagine doing a 50-question block, all random subjects, i.e. some clinical, some admin, some stats, okay, but in the right proportion, i.e. 80% clinical, 10% stats, 10% admin. Then we have a session where I go through those 50 questions. We go through why you got the ones you got wrong. I go through the relevant guidelines, how to do the calculations, so you understand why. Then you have a break. Then we do another 50. Then you have lunch. Then we do another 50. And then you have a break. Then we do. So by the end of the day, you've done basically a full mock, but in timed conditions. And we've reviewed 200 topics, and you get a huge course booklet with the teaching slides so that you can quickly then revise those. And the full mock is made up in the right proportion, 80% clinical, 10% stats, 10% admin. And then we send you another full online mock, 200 questions, 80% clinical, 10% stats, 10% admin, to do as a second mock. This one's really realistic. A lot of doctors have scored 1 to 2% of what they score on our online mock in the real exam, okay? So the next one of these is running on the 2nd of August. It's a full day live stream from home. For those of you sitting in July, you can access this, instant access, the latest one is recorded, so it's up to date. So in terms of revision planning, for the July exam, you've got under 2 weeks now. If you haven't already been taking part in the AKT 30-day challenge, which has been in our AKT study group, or you can sign up to the email so that you receive it by email. Please go through the ones that you've missed, days 1 to 15. I think we're on day 16 today, or day 17 today, and do the last 13 days. Each day, we basically do a question in exam conditions, then I revise the guidelines, some clinical, some stats, some admin. They're all high yield topics, okay? And then the very last day, we do exam day tips. Please revise key stats, key admin, and all the high yield clinical topics. Go through the AKT high yield checklist and make sure you've ticked it all off. If you fail by 1 or 2%, and there were anything in that high yield list that you didn't read, you kick yourself, because examiners are telling you, we're going to put this in the exam. That's how often those things come up. Do at least 2 full mock exams in timed conditions. So we've got a full mock that you can buy separately. Like if you didn't want to do this and you just want the mock, you can do it. It's £30. But if you do this, it's included for free. We have another one on our online revision service that's different. If you do that one, that's essentially a third full mock. Okay, but do at least 2 in time conditions. And then after you've done those, go over any gaps and any areas you're less confident in, and just do that between now and the last exam. So, in terms of a timetable, what I'd say is this weekend on Saturday, try to cover stats and admin. So if you do our webinars, stats is 3 hours, admin is 3 hours. You've done those things, okay? On Sunday, go through all the high yield clinical. It's going to take slightly longer, okay? And then do some questions and maybe revise and practice some questions from stats and admin, okay? During the week, try to do on the RCGP self-test, you can do like a pick and mix, like it gives you random questions, 30 or 50 or 60, like a mini mock. Try to do one every evening, so you're building up stamina, okay? Next weekend, you're now getting closer to the exam, do 1 full mock, or the AKT 200, okay? And go through the answers and explanations. The next day, do the full mock. Then you've still got a few days to go through any gaps that you've identified by doing those timed mocks and developing your exam technique, to just do that reading. And then that will take you up to the exam. And then come the results, just let me know that you smashed it, okay? It will make your day, it will make my day, all right? We have something called the AKT Booster Bundle, where we've put all of this together in one, okay? So I'll pop the link to that for those that are sitting in, I've put that into the links. So what the AKT Booster Bundle covers is our AKT 200 mock crammer, okay? Which is, I'll show you. Okay, It's down here. Okay, so basically you've got our AKT 200 question crammer, which is 8 hours of recorded video in those 200 questions with topic reviews with the course booklet. Then you get the 3 masterclass webinars. So stats, 3 hours, admin, 3 hours, high yield clinical, 3¼ hours. Then you get another full AKT online mock. So it's just over 25 hours of learning, of which 16 hours is recorded videos. Okay, that's over 500 high yield topics and questions. A lot of these topics are going to come in your exam. Okay, so you could subscribe from anywhere from 1 month to 12 months. It's all up to date for instant access. So it's normally £380, which is already £90 cheaper than if you bought these things separately. So, you know, that 25 hours is a really useful way to do in those last 13, 14 days that you've got left to really boost your score. But if you use the code AKT15, all lowercase, no space, by midnight tomorrow, it will expire after that. The code will still work, but you get a much smaller discount, okay? You get a 15% discount. So instead of paying £470, you'll end up paying £323, saving over £150, okay? So that's the booster bundle. You'll find that really helpful if you're doing the exam in July. For those in August, you've got 6 weeks. By this stage, you should have covered at least half of your revision because you will have been preparing. You would have allowed at least 3 months. That's a minimum recommended time for your full revision. So you should be more than halfway by now, okay? What you want to do between now and the exam in these last 6 weeks is systematically cover any gaps in the curriculum. So download the curriculum, okay, from the Royal College website. Any gaps, read through them. Work on exam technique by doing some timed mocks, by doing the webinars, revise stats, admin, high yield clinical, revise key guidelines, okay? And then what you want to be doing is, between now and the exam, you want to be doing as many online revision questions as you can, and then the same plan for the last 2 weeks as the July cohort. Revise stats, revise admin, revise high yield clinical, revise the clinical checklist, do at least 2 full mock exams, 3 if you can, okay? And we have actually a bundle that puts all of this together and more. It's our AKT Pass Plus bundle, which is 110 hours of learning, just over that. So you get access to how to pass the AKT masterclass webinars, 2 hours online recorded. Then we've got our AKT preparation course, which is on the 18th of July, or you can access the recorded version. You get 1,700 online questions, including a full mock up until the exam. You get the clinical case cards, which we'll post out to you. You get the stats webinar on the 21st of July, admin on the 22nd, high yield clinical on the 23rd, AKT 200 you do on the 2nd of August, then do the full mock exam, 2 of them we'll send you, 1 on the 8th, 1 on the 9th, and then between the 9th and the 18th, that last week, basically watch these back, because we'll send you the recordings as well. Watch, go over any gaps, practice any gaps in your things, and then do a few more mini mocks from the RCGP. So again, if you bought all of this separately, it'd be over £900. It's already discounted to £695, but if you use that code, it will give you over £325 of total savings. You'll only pay £590. So that I'll just show you on our main website, emedica.co.uk. Go to AKT, it's the second one down, Pass Plus, okay? You can just click here. These are all the dates for July. We will run that again for October and so on, okay? So that's what you might use, or how we might help you and give you a specific plan, so you know what to do every so often. You know, you've got this many days and this many, 110 hours is about half. It takes about 200 hours of study to prepare for AKT. So, you've got 6 weeks left, but usually people do more intensive revision in the second half of their revision than in the first. So that's why that's 110 hours, okay? So I'm going to summarize, because anyone that's got questions, stay back and I'll answer questions for the next 10, 15 minutes. But I know some of you haven't got questions and you're going to leave. What I want to say is, even if you're sitting the exam in July, or you're sitting your exam in August, you might think, I've only got so many days, or there's not much time. If you're willing to put the hours in, and if you're willing to work efficiently, you could read all of these things yourself. It would take you weeks to assemble all the admin stuff. We've done it for you. We spent weeks, hundreds of hours collating all the data so that you can learn it all in 3 hours. You can be really efficient. We can help you. Things like the case cards, hundreds of people hours reading nice guidelines to make them really concise. It's just going to speed up your learning. So, what I would say to you is what Muhammad Ali said: don't count the days, make the days count. Never give up hope, no matter how little time you've got. If you keep pushing, keep working, keep trying, then, prepare and you will succeed. For those leaving, I hope you found it helpful today. I will send out the post-course links. I will send out the handouts, the teaching slides, and a recording tomorrow evening. Okay. So all the best with your exam. Keep in touch. Let me know how you get on. And you can also find lots of other free resources on our YouTube channel. So we've got all the lockdown learning webinars. If you didn't attend any of them, there's 9 hours of CPD, lots of AKT questions there. The AKT 30-day challenge is free. There's all of that material and more, okay? But, if you want help, we've got all of those things that I talked about. You can get any of them separately if you want, just the course, just the 200, online revision, just one of the webinars, just the case cards, or you can get them as a bundle if you want to save, okay? So thank you very much. Have a good evening. I'm just going to spend 10 minutes answering questions now, okay? Someone's asked, when you get your AKT score, do you get a breakdown, and what is in the breakdown? Yeah, so you'll be told your total score, and you'll be told your score in clinical, your score in stats, and your score in admin, okay? Remember, you don't add those 3 scores together and divide by 3 to get your total. You've got to weight it 80% to clinical, 10% to stats, 10% in admin. For example, someone that gets 60% in clinical is going to fail AKT. Even if you get 100% in stats and admin, you're going to fail. Okay, because clinical is 80% of the questions, 160 questions is clinical. If you don't do well in clinical, you cannot pass AKT. Someone said the live webinar was funded by their deanery, and then they also self-funded the RCGP one. Can you watch either? Yeah, so if you've been to any of our webinars, live, we automatically include 1 month's access free. You just need to email the team and we'll set it up for you. For people that just buy access, you buy whatever period you want. You can subscribe for 1 month, 2 months, 3 months, 6 months, 12 months, it's up to you. But if you book any of the live ones, we include 1 month free, which is worth £79 for any one webinar. Someone said, what do you recommend for resources to study for admin? The admin webinar. Rather than reading 20 different places, 20 different websites, just come to the webinar. We've made it easy for you. We've covered all the key things that you need. Enough for you to get a really good mark, okay? Someone also just wanted to know about other useful resources for general reading. You probably haven't got much time for this now if you're sitting in July, but for August or October, this is the core text for AKT. If you don't have this book, you're going to miss out on a lot of valuable reading. The Oxford Handbook of General Practice, make sure it's the 5th edition, please. The 4th edition is 6 years out of date. It's pointless, okay? Because so many of the guidelines have moved on, you'll actually get the answer wrong because you're following old guidelines. Do you see, okay? Even this has got some things that are out of date, okay? Because from submission to publication, some things change. But this was published in June 2020, so it's relatively up to date. Whereas the 4th edition, which you might see floating around in some bookshops, the 4th edition is from 2014, 6 years old. It's far too old. Okay. Someone said, will the AKT provide the volume or amount in the glass or bottles? It generally will, but not always. So you should know that a pint is 568 mils. Okay. Someone said, what about the October sitting? So if you're preparing for the October sitting, then you could do the Pass Plus. We have that available for October. But you also might want to do the Pass Guarantee package. Okay, so for the October sitting, that's going to start on the 30th of July. It's a 90-day program. Every single day you get an email from me with a question of the day, a link for some further reading, and a link to do some questions on either our online service or RCGP self-test. Okay, throughout the 90 days, you will also cover 2 full-day courses, 9 webinars, 3 full online mocks, over 3,000 questions, and essentially, you don't have to think about anything. You just have to do the work. As long as you do the work within 24 hours of it arriving in your inbox, we guarantee you'll pass, because we make sure that you get a good handle on stats, admin, cover all the higher clinical topics, cover the curriculum in a systematic way, keep consistent, build up intensity, but also the first 60 days, we gather data from you on areas you do well and how well you do, because we'll ask you to send us, your scores. And then our team will make each doctor an individualized plan for their last 30 days. So everyone has different revision allocated to them based on areas that you might not like to read, but we've identified from data are your weaknesses. So we make sure you conquer your weaknesses. So then even if you're busy, look at this, someone with a 2-year-old baby and working A&E, like probably 2 of the hardest things to deal with when you're trying to prepare for this. And they still manage to get a really good score because they like the fact that a little bit often every day do the work and then additional stuff on stats, organization, and high yield things specific to them. Okay. So, it's over 200 hours of learning. Okay. It's £895. I think there's only 2 spaces left for the October program. The reason we take a limited number is because our team have to analyze your data and give each person an individualized plan. That's really labor intensive. So we can't take loads of people. Otherwise we won't be able to give each person. And you can see the dates there for the October program. That's starting from the 30th of July. But again, you could just do one of the courses. You could do any or all of these. You could do the Pass Plus. Okay. It's entirely up to you. Okay. Someone said, how much is the recording? So the recordings for any of these are the same price as attending the live stream course. So for example, this is £240, the same price as the recording. as it is to attend. Whereas if you attend in person, you get also a month's access to the recording for free. So it's worth 240. The webinar is £79 for one, £199 for all three, and so on. Okay. Someone said, what are the recommendations with regard to childhood immunizations? You don't need to learn the dates that people have the normal immunization schedule. They won't ask you that. You do need to learn things like which are the live vaccines that are not safe for people to have, who are immune compromised, or, vaccinations in pregnancy or vaccinations for special groups. But the childhood immunization schedule, you don't need to learn that off by heart. They won't ask you questions about that. Who's eligible to sit exam in August 2020? Anyone in ST2 or ST3. When are the live webinars? They are the full day course, 18th July, stats 21st, organizational 22nd, high yield clinical 23rd, AKT 200 2nd August. Okay. Someone said, out of 160 clinical, how much one needs to pass the exam? Well, it depends how well you do in stats and admin. What you need about 72% in total if you want to be sure of passing the exam. That's the highest the pass mark has been set. Okay. Generally, if you can get 80% plus in stats and admin, you can get away with 70 in clinical. Otherwise, you need at least 75% in clinical if you want to have a decent chance. If you do really badly in stats and admin, you need 80% in clinical. You can't pass. Okay. Someone said, are all your courses covered by deanery study budgets? That depends on your deanery. So, some deaneries cover our pass guarantee. We've had people claim that. Okay, some will cover the pass plus, but not the pass guarantee because they have a cap of £750. Some will cover the course and the webinars, but not online revision or the case cards. So it's up to you to contact your deanery. Some deaneries directly pay for some of these things. So we run our full day course for Health Education England KSS in June. And for East of England, we've been running it for the last year or so. They're already going to run it for their cohort in September. East of England have also bought the stats and admin webinar for some of their trainees. KSS bought some CSA cases for their trainees, although that's ended now. Those were eligible. They got access yesterday, so that's ended now. Okay, so just contact your deanery and see. Okay, good. So that's all the questions that I can see there. So thank you very much, everyone. That's 9:30. We've run over 15 minutes. I hope that's been helpful. All the best, and I hope to see some of you at some of the courses or the webinars if you want to sort of hone in and focus. But I hope you found tonight helpful. Have a great evening. All the best with the exam. Prepare, and you will succeed. Okay. Thank you so much, and I leave you with this.